Check. Hello. Check. 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 Hello.
Good evening and welcome to this CME on the advancement in low vision practice and awareness. We are actually waiting for our chief guest, Dr. Professor Jeevan Singh Titial to come, but I think since we're already behind time, we'll start off. So we are having this CME with Community Eye Care Foundation under the aegis of the Maharashtra Ophthalmology Society. And we have here Dr. Santosh Agrawal, President of MOS, Dr. Atul Kadane, Secretary of MOS. They have traveled all the way from Aurangabad and Amravati. And we have to thank past President Dr. Santosh Bide, who helped us get this place. And the Pune Ophthalmology Society, represented by Dr. Mandar Paranspe. Here we have three eminent speakers. One is, I would request Apurva to welcome Dr. Deepak Bagga. Dr. Bagga is the director of the Low Vision and Rehabilitation Center at L.V. Prasad Eye Institute, and in his career of last 25 years, he has served in many places, including the Shroff Charity Eye Hospital. And cortical visual impairment is something that is very close to his heart. So thank you for coming down, Doctor. And Vision Aid USA, who are our partners and through whose technical collaboration we run this center, is represented by Ms. Devi Uday Kumar, who's flown in all the way from Chennai. I would request Apurva to welcome Ms. Devi. She'll be telling us what Vision Aid does. And this project also would not have happened without the help of the Rotary Club of Pune Downtown and CSR through the DuroShocks company by Mr. Anil and Niru Goyal, and my wife, Dr. Bhageshri Gokte, Yesdi Batliwala, and Ashish Ray. We also have here with us a large-hearted Mr. Vikram Desai, who very, very generously has loaned us free of charge the space that we use for the Low Vision Center. I would request my teacher, Professor A.N. Kulkarni, sir, to please felicitate Mr. Vikram Desai. Mr. Desai has his Manubhai Desai Charitable Trust and the Desai Electronics Office, which is what he has loaned for us to start that center. Thank you, Vikramji. And the gentleman who is hiding, whom I can't see much, is, of course, Dr. Kuresh Maskati. So Dr. Maskati is a star. Dr. Maskati needs no introduction. And when he is here, we know that his fan following, especially in one particular gender, will be here in greater numbers. And we will always have a great audience. Thank you for coming down, sir. I would request Dr. Supriya to welcome Dr. Maskati, sir. And it is with Dr. Kuresh Maskati's what shall we say, his good word that he put in for us that we could get this center from Vision Aid USA when they were looking for a partner in Maharashtra. And Dr. Supriya, if you can also welcome all the office bearers, Dr. Santosh Agrawal, President of MOS, Dr. Atul Kadane, Secretary of MOS, Dr. Mandar Paranspe, Treasurer MOS and President POS, and Dr. Rahul Deshpande, the Chief Medical Director of HV Desai Eye Hospital, who also heads the Low Vision Center there. I think Titial sir is yet to come, so I think we can start off with Devi's presentation till sir comes.
So good evening, everyone. Many of you I have met during the hands-on session. Hope you enjoyed the hands-on session of all the low vision devices and you got to know about smart vision glasses. And welcome dignitaries of MOS and welcome, sir. As a representative of Vision Aid, I proudly represent a team of Vision Aid for its comprehensive strategy and efforts for enabling, educating and empowering visually impaired. For a few minutes, I'm going to tell you how we are incorporating it across India. So we all know that there is a huge burden of visual impairment and it impacts nearly 9.2 million people with blindness and 49.1 million with moderate and severe visual impairment. It not only impacts just the visually impaired, but it impacts the reduced employment, elevated mortality risk, education loss, especially for children, and due to which there is productivity loss and a lot of impact is there on Indian economy. And about 90% of the visually impaired are from low to middle socioeconomic condition. And to alleviate all of these burden, Vision Aid, by its mission, was founded in 2004 with a mission to enable, educate, empower the visually impaired to live with independence and dignity. And we advocate and facilitate the creation of a network of vision rehabilitation centers, which can offer a comprehensive model, which you can see in the Vision Aid Wheel, we call, which give out the information about how we enable, educate, and empower. And we want all of these centers, not only in the major cities, but also in the underserved regions. I'm proud to say that we have spread across nearly 15 eye hospital locations, which serve as resource centers, including our very own Community Eye Care Foundation. And there are nearly 30 plus blind schools, which serve as resource centers. And through our Vision Aid program network across India, we are trying to enable the mission of Vision Aid. And we advocate this comprehensive model, not just the assistive devices, but also the training of assistive technology, which you saw during the hands-on session. And we also try to provide training for professionals and capacity building by our very own partner, Preeminent Eye Hospital, LVPI. Previously. So with blind schools, we support in aiding infrastructure and also assistive devices like smart vision glasses, smartphone, and tactile books. We also operate and partner with community organizations based in Agra and Vizag to provide training in terms of skill development for visually impaired. And we also partner with NGOs like Help the Blind Foundation, Raise Lane Foundation, and Trees for Life to provide affordable assistive devices to the needy. So to talk about Community Eye Care Foundation, they have been our partners, and I'm very proud to have them as partners because the team led by Dr. Parikshit and Dr. Supriya, they have been doing a wonderful job in not only in the clinical base, but also mainly on the outreach. They travel to schools for the blind and completely do an assessment for all of these children at their grassroots level. And they go back and do a compliance of whether the people are using the devices and what more to be done to empower and educate them. And they have, I proudly say that they have been conducting a lot of orientation programs for over 200 professionals. And today we saw a lot of people, mainly students on optometries, who have been educated on the role of low vision and devices. And Vision Aid specifically focus on the care for cortical visual impairment. The burden is huge again. 30 to 40% of children with visual impairment are having CVI, which is cerebral or cortical visual impairment. So we try and along with our partner LVPI, we give training and capacity building to professionals for giving services to CVI children. We also enable centers to offer training to infants and children in holistic management of children. It not only improves the well-being of the child, but also holistically improves the family's well-being. So the next highlighted programs which we focus on is educating the visually impaired, mainly on skill development, training at partner locations, and as well as in blind schools. We offer direct virtual online trainings. They are it's segregated as basic, advanced, and technology courses. We also offer residential training programs at Vizag and Delhi, and whenever required, provide scholarship. Our technology courses are specifically designed to empower, which is the third highlight of visually impaired programs for visually impaired. So our technology courses are one of the flagship programs is digital accessibility testing and training. I must tell you that this is one of the flagship programs, and nearly 40 to 50% of the students get empowered and employed. So they also not only get placed in other organizations, they are also employed under testing and training under projects of Vision Aid to producing highly accessible digital systems. Another flagship program is Python programming, a programming language learned completely using screen reader softwares, which is completely possible, and people and students are getting placed. The next highlighted focus we have is innovative technology. In a short while, we'll see a presentation on smart vision glasses. We are actually looking out for these innovative technologies and cutting edge assistive devices, because one of the barriers to access to these devices has to be elevated so that people get all of these devices, technology driven devices, at affordable costs. So we are proud partners of smart health technology in okay, just a slide back. Yeah. So Mr. Ramu Mutangi is here. He will be talking about smart vision glasses. He will also demonstrate and talk about the future generations, if possible, and tell you how the innovative technology is going to help the visually impaired. And we are also partners with Orbit Research, which provide cost-effective CCTVs, which are nothing but portable digital magnifiers. They are mainly focus on become a reading companion for visually impaired, mainly people with low vision, and help in educational challenges. The next highlighted program is smartphone programs. A lot of smartphones have been given to unaffordable, and just giving out smartphones would not be enough. Training them in mobile technology is important. So you just saw Dr. Deepak had demonstrated how a smartphone can be used for all of the visual, transferring visual information to a visual impaired. So that's the focus. So we one of the highlighted programs is smartphone. We are proudly want to present that by in the year 2023, we have touched nearly 20,000 plus beneficiaries. Thanks to partners like Community Eye Care Foundation, we were able to, most of the beneficiaries are from hospital partners, and their training programs have extensive curriculum, number of sessions. For advanced level and intermediate level programs are huge. So they come under direct training, but rest of the other partner locations and counseling and complete educational counseling and vision assessment is done at our hospital partners. If not for them, we cannot actually move forward towards our vision and mission. Thanks to you, sir. Thank you, everyone.
Yeah, before we go on to our next speaker, Dr. Deepak Bagga, there is one felicitation I forgot. Mr. Ramu Mathinge, sir, is the CEO of SHG Technologies, and they are a new innovator who have come up with the smart vision glasses. With these glasses, even somebody who is completely blind, even such a person can see with the help of AI, artificial learning applications, and we will be, please, sir, please. And he is a ex-naval officer. He is the armed forces, and this is something that he has done after his retirement, and we look forward to hearing from him. Thank you, Ramu sir. Thank you out something like a smart vision glass to a child. That's Oryx technology. The technology that SHG has is one generation after that, and they have done it at 1/15 the cost of what was developed in Europe. So they are based in Bangalore, and I think they will kind of revolutionize the way rehabilitation is done. Thank you for coming, sir. Deepak sir, over to you.
We'll try make best use of it through the case discussion, case presentation, because that I think clinicians are able to link, understand that works, what works best. Okay, then I need to forward. Yeah. Please. So can you go to the next slide, please? Yeah, how many of you can identify? Just raise your. Okay, next. This cricketer from Guntur. If anybody can identify him, raise your hand, please. Even you cannot. Okay, go to the next. So these are his achievements, if you see. So many times he has got World Cup for the country. So captain of Indian cricket team, blind cricket team. So we don't recognize them that there's a blind cricket. So a blind person can also play cricket, can bring World Cup for the country, but they are never highlighted. So yes, so Purva's case, my cases will tell you that what is possible through this technology, through counseling, guidance. So we'll look into some cases. So that is for people to find out his name. I will not reveal the name. Go to the next slide, please. We all are familiar with this definition. We use it left and right. But whenever we are using something, we should look at the asterisk mark, which is there. Okay, so when WHO came up with this definition, what they said, go to the next one, this should be used for reporting purpose, not for providing the care. So there might be people who may not fit into the definition, but may still require services. So this definition does not include people with hemianopia, people with impaired contrast sensitivity. People may have 20/40 vision after LASIK surgery, after everything treatment is done, having PDR, you have done well laser, they have impaired contrast sensitivity, impaired near acuity, may not fit into this, but may require these services. So needs to be identified and referred. So there might be people with mild impairment who may be missed out if we consider this for providing care. So for provision of care, you consider functional problems. If they're saying that they're not happy with their vision, they're not able to perform their day-to-day tasks, please refer them irrespective of the vision. You don't need to wait, even in the definition says, even after treatment, best possible correction. In some cases, treatment is never over. One laser, second, third, fourth, fifth injection. So the treatment continues, one grafting, second grafting, and that is a better eye or best eye for the person. So both the things can run parallel. So while you are taking care of them, their medical treatment, waiting for the full recovery to come, we can always guide the person that in the interim period for them to function, these are the things, there are solutions which are available. So both can run parallelly and go on the vision rehabilitation. So go to the next one. These are the purposes which are suggested by American Academy of Ophthalmology. First one, maximizing access to printed material, improve ability to accomplish activities of daily living, perform tasks of interest, improve safety, optimize social participation, improve psychological status and adjustment to vision loss. Okay, so what happens is if person has difficulty in mobility going around, safety is a concern, they start minimizing social interaction, something which is essential only they attend to. Something which is optional, they start avoiding those which are optional. And certain essential aspect also, they start learning to avoid those things, escaping from those things. And that impacts their emotional well-being, affects their overall quality of life. And that is where our interventions might help as we take into one. So maybe what I'll do is I will begin with two cases which Apurva has to present, and then I'll continue with the other case presentation. We'll need to switch over the slides, please. Just I'll turn this off. Yeah. Yeah. So her case reports. So she has two case reports.
So I did not even put my name and all. Should I put anybody?
No.
Yes, sir. I will be.
So Apurva Shitola is the person. She manages the low vision services in Pune. So I would invite her to present two cases which she has managed so well, that how the intervention has brought the changes, and then we'll continue the discussion. Apurva.
Good evening, everyone. So we'll be discussing mild to moderate visual impairment. So this was case one with mild visual impairment. This was a 9-year-old male student studying in 4th standard. So he had a hobby of creating comics. So he would actually draw the comics and write the dialogues and everything. He used to play ukulele, but the parents complained of the child had neck pain due to reduced, I mean, he had a very short reading distance, due to which he would just bend his neck all the time, and the bad posture resulted in continuous neck pain. So the cause of low vision here was broad cone dystrophy. The family history had the grandmother with visual impairment since young age, but the cause was unknown. He was accompanied by the parents. So usually in the low vision history taking, we ask all these questions to understand if the patient is independent, or he has dependents, or he has come alone, or he has got someone with them. And if the patient, the attendant is the first family member or neighbor or someone, to understand if he has enough emotional support from the family. So the duration of vision loss was since birth, but the nature was quite stable. The education, as I told, he was studying in fourth standard and he had never been introduced to previous LV care, low vision care. So you can see he loves to draw comic books and he also plays ukulele. Yeah. So use of glasses, he's been using the current prescription glass for 3 years. The activity limitations as reported by the kid and the parents were, he was unable to read books for long hours. Like due to the continuous neck pain, he had very reduced attention span. So he did not like studying basically, which can be problem for all the young kids, but he had a problem of neck pain and that is why his attention span was quite less. Cannot write in straight line, difficulty to see in dim illumination and photophobia. And he would manage board work. Like he had enough visual acuity, residual visual acuity, we can say. And with relative distance magnification or approach magnification, he was managing his board work with sitting on the first bench. On the previous slide. There were no specific lighting needs. Mobility had no problem. Bumping into objects was also not reported. Delayed adaptation time was also not reported. And he could manage his daily living skills. So the ocular examination showed that the anterior segment was within normal limits. The posterior segment on indirect fundoscopy and fundoscope showed that there was mild disc pallor. There were pigmentary changes over the macula and pigmentary changes over the peripheral retina. The ERG, which was done elsewhere, showed that there was reduction in photoreceptor function in the peripheral retina, which was more in left eye than the right eye. The color vision was also abnormal, recorded on Ishihara plates. Now, the distance visual acuity, which was recorded on Snellen chart, which was recorded with correction, was 624 parts for the right eye and left eye 624 parts. And binocularly, you could see 6 by 36. Near visual acuity was recorded with Bailey-Lowy word reading chart. So the Bailey-Lowy word reading chart is used for low vision patients because the first letter, it is N80. So it is quite visible to the low vision patients, even if they have very reduced near vision. So on that, he could read N6, again at a very short distance, 10 centimeters with an external light source. Observation was made, like the fixation was seen with observation, which was centric. The present glass prescription is given. Refraction was done again objectively and subjectively. Objectively, the value is by dry retinoscopy. And the subjective value showed improvement in the binocular vision. There was not very significant visual acuity improvement, but it is good, like more than enough for a low vision patient. Yeah, so this was So the observation, this was after on the follow-up visit 2. Patient's reading distance had changed from 10 centimeters to 30 centimeters. So the patient complaint of neck pain had reduced considerably, which increased his attention span in studying, and he could study well. Like the parents observed that their child was studying more than the usual because his neck pain complaint was gone. And yeah, the patient, okay, that's okay. We can shift to these two. So this is a case of moderate visual impairment. This was a 94-year-old female retired editor and journalist. So she was working in Times of India as an editor. So she was an avid reader all her life. And she loves to go for walk, watch television, play with grandkids, read newspapers, everything. So her duration of vision loss had been 2 to 3 years. The nature had been progressive due to her the cause of low vision here was dry RMD, both eyes. Now she was using glasses only for reading. Activity limitations. Now she's old. She does not have a really active lifestyle. So the main activity she loves doing is reading. Reading and signing documents, checks. So specific lighting needs, prefers bright light for reading anything. Mobility had no problem. Bumping into objects, delayed adaptations was not reported. Again, she could manage her daily living skills. So anterior segment was both eye pseudophakia. Posterior segment showed dry age-related macular degeneration. Distance visual acuity for the right eye was 6 by 360. We had calculated this on receding logmar chart, which is calibrated for 3 by 30. And then we have changed it to stellar equivalent. So left eye was 624 parts. Near visual acuity on Bailey-Lowy word reading chart again was N20 at 15 centimeters with a external illumination. So this is the present glass prescription, and refraction over here again was done with dry retinoscopy and then subjectively. Yeah. So the refraction improved her visual acuity from 3 by 360 to 6 by 120. And optical devices, sometimes we overlook the refraction part, but if at all we try the retinoscopy, and so sometimes we can improve with refraction also. +4, with the add of +4, the visual acuity was improved to N12 at 10 centimeters. Then the optical devices trial for distance was not given because the patient was managing her daily living skills. For near, a 4x stand magnifier trial was given, N6 with good tracking and localization, but needs extra illumination. 3.5 portable digital magnifier, again N6, it was very comfortable for her. And non-optical devices trial, we gave them a signature guide. The patient preferred a signature guide and a portable digital magnifier because they were able to change the contrast, increase the magnification up till 32x as well. So there was no magnification constraint over there. So this is the 3.5 inches portable digital magnifier, and a signature guide looks something like that. So you can put the signature guide over the check or wherever you want to sign, and there's a high contrast with the background, and there's a small space to sign. So these were small changes we had asked her to do in her daily life, which helped her a lot. Again, we suggested her contrast enhancing measures like movable overhead illumination. If at all she wants to read with her +4 reading at, with the overhead illumination lamp source, she'll be able to see at least N10 and N12 font. Magnification or relative distance magnification, nothing but you move close to the TV and see it. And we counseled for vision enhancement techniques to use in smartphone easily. So there's one application called V-Zoom Magnifier, which is available free on Play Store. So which works similarly like a portable digital magnifier, but it does not have a stand. So we suggested that and explained about eccentric viewing technique. So observations after dispensing LVTs. So the patient being an avid reader, and she, due to her current prognosis, she was not able to read much. But with the help of a portable digital magnifier, she was able to do that, which helped her to, that her emotional well-being, her psychological well-being was good. So despite limited visual impairment and visual function, the patient reported increased independence in performing activities of daily living due to improved. So her the even like really small tasks like reading or things, she would ask her grandkids to read her out something if at all she wanted to read something. So that was gone with a simple aid. So that helped her a lot and it made her very happy. So yeah, that's it. Thank you. Oh yeah, Mr. Dr. Deep. Yeah, any questions? It's a number infrared filter. So there's a number written on over there, which would signify the percentage of UV transmission. So over here, this was 465 yellow filter with 80% transmission. So yeah, there was a study conducted and we had, so the filters were clubbed according to different retinal anterior conditions or posterior segment conditions. So gray filters usually work good for OCA patients or RP patients, and anyone with delayed dark adaptation, we cannot give a gray filter because they already have a delayed dark adaptation. And if we give them a gray filter, that would again reduce their visual acuity. So over there, a red filter or an orange filter has worked. So based on these different conditions, we have clubbed in different filters for that specific condition, whether it is anterior or posterior.
Yes. So like a very good question, sir. That why yellow filter? So yellow filter is known that it enhances your contrast. So usually the filters work in, you can say, three important areas wherein it will help you. One is the contrast enhancement, which it provides. The second is relieving their glare symptoms. So glare symptoms can be reduced with the gray filters, other neutral density filters as well, but may not enhance contrast much. And the third thing is that the harmful radiations, which people believe that, okay, UV rays, infrared rays will be harmful. So those are also incorporated into it. And usually, if people have a lot of outdoor work and they are suggested to use this protective wear. So it depends on how quickly, so how soon you're referring that patient. If you're referring the day it is diagnosed or the way person has started exploring it, yes, they would have a lot of botheration because of this scotoma. But if the referral, by the time people reaches us, it is about 6 months or a year, they would have already developed their PRL, preferred retinal locus. So they would find out which angle they have to see and they're able to visualize better. So they will say at times that people complain that they are not making good eye contact. And if they look straight, they are not able to see things clearly. So over a period of time, so beyond 6 months, or say if people come, usually they would have found out on their own. If they are reaching us early, then yes, there are training programs which can help them improve that.
If patient are under treatment for ARMD and there is a treatment going on, injections are going on, when the doctor should refer the patient to you?
Like I said earlier, it can run parallelly. So if say somebody's even visiting today and then they say that next week I have certain important meeting, I want to read something, and you're giving injection, you're saying it will take 6 weeks or a month to see the result. How do I manage? So you can say for temporary, you can explore what options are there. So we can help them then and there itself. So there are people who may be using it for temporarily for that duration. If things improve, they may not need to. If things improve to a certain level, it may not come to the normal, but they may say now today's moderate impairment, they may improve to the mild impairment level. The magnification we may need to change of their devices.
Second question, if patient has visual impairment in one eye and he cannot drive because he don't have any visual field in that area. So how you can help them?
So for one-eyed person, monocular vision loss, so there are guidelines for them to get driving license. So you need to test their So the loss of vision, I think, has to be longer than 6 months, and the visual field has to be 120-degree, and the other eye has to have perfect vision, which is 20/20. So if they have 20/20 vision, 120-degree field intact, and over 6 months period, which means they have been given adequate time for adaptation so that they can scan and manage. Then, so those are the three guidelines which are there from transport authority. So based on that, then you can recommend them.
How you can help?
You can't expand. We don't have anything to expand the field. So monocular vision loss functionally do not find any utility reaching out to low vision specialists because we are looking at always with the better eye, and if there are functional limitation, even with the better eye.
Expanders are there, expanders or reverse telescope. If you use some extent, they help expanding the field. In advanced glaucoma cases.
So there are you may have multiple types of field loss. One is we call homonymous hemianopia. That is where peliprisms might help. Okay, therein also the literature suggests only 50% people find that useful because they are not suggested usually on day one when they report us the hemi field loss. They're given again 6 months time for adaptation. If they learn the scanning, because these are not in reality field expanders, that is misnomer. They are field awareness system. So people get to see something which is in the non-seeing area that is brought to their seeing area to avoid doubling of vision or confusion that is fixed to their, not in the central position, but in the peripheral position, those peliprisms are there. So for hemianopes, homonymous hemianopia, yes, peliprisms work. But the concentric field loss, which you see in patients with RP or in patients with glaucoma, field expanders, which you see in the textbook are described, practically doesn't work. We have those mini fires available. We have given trial to a couple of patients, not couple of patients, many patients who came with that expectation that things will improve. Didn't make much difference. The reason is when you're, say, minifying by half to get field of view, to double the field of view. So somebody having 5-degree field of view, even if I make it 10 degrees, that suffice for them to go around. And with that minification, the depth perception, all those things will not help. The other thing is the acuity drops to half. If somebody is having acuity of 20/60, it becomes 21/25. So the details are lost. So again, people do not find it much useful. So we have tried on many patients and then it didn't work. So theoretically concept, if I test it, I can show it that yes, field has doubled, but does it practically work? People find it useful? No. So for concentric field loss, advanced field loss, orientation mobility training is the standard preferred practice to suggest them to undergo training.
What is the teaching itself?
So there are a couple of different ways wherein, so earlier the old method when people didn't have computer-based training methods and all those things, these new, which are apps which are other available. Earlier, so they used to have that, okay, say if you've written the words or letters initially, and then you have 3 lines above, 3 lines below, and on sideways, and then you ask them to look at this line and then see, so at what angle, in which direction looking or focusing, you're able to visualize it better. And then you train them that, okay, in this direction. So initially you have to find out where the preferred retinal locus. So that is how the rehabilitation therapist used to sit with the patient, provide them training, first with the letters and then with the words and then with the sentences. And it used to run for say about a week or so to find out their PRL and then train them in that aspect to improve there. And then over a period of training, you'll find that things have improved. Now people have got microperimeter and all those things, and then they try giving therapies over there with the sophisticated equipment.
What was the diagnosis in first stage, 9 years old child?
So it was rod cone dystrophy. Rod cone dystrophy. So it was,
All this child seeing many ophthalmologists the last 9 years.
yes. Yes, so the ERG and everything, all the reports were from another hospital. He had been diagnosed already. So
Seen by the school.
not for the low vision aid, not for the low vision aid. So the parents were absolutely unaware of low vision, like low vision aids existing. Yeah,
School testing, the school screening was also.
no. So, yes.
Thanks, Apurva. I think in the interest of time, I'll
Media, the people I think is more aware of, and they will go and.
correct.
There is more identified even the brain.
Correct. Like I showed you those 2 pictures One is celebrity, another one nobody knows about him. Okay, so both are but World Cup winners. So we'll go to the next slide, please. So we'll look into some aspect of assessment of persons with low vision, various approaches. Apurva has covered, I think, 80% of things. So 20% I'll touch upon. Go to the next one. So this case having very long follow-up. So say from 2011 to 2023. So 12 years follow-up. When she presented for the first time, I'm not going to the clinical detail because all of you are familiar what are the features of RP. So was diagnosed to have RP, was having symptoms of gradual progressive vision loss, night blindness. And these were the two primary complaints which she had. She reported with her parents. She was in class 2. Go to the next slide, please. And if you look at the acuity with the correction, so with the refractive correction, it was mild impairment. And that age, it's hard for you to do the visual field testing and other things. Go to the next one. Near acuity is N6 sufficient for her to manage short working distance. She was sitting in the second row. So the simple approach, a relative distance magnification, you suggested to go sit in the first row with the glasses. If she can manage, yes, she can manage. So that is what we suggested. Go to the next one. And she was very excellent in the studies. There's no problem with the academic performance. So we suggested continue with the same glasses because there's not much difference in the prescription. 6-month-old glasses she was using. Dry cyclorefraction, everything was done, and suggested to sit in the front row. At times, because of the height, they are not allowed. So you make a recommendation letter saying that, okay, allow her, considering her vision problem. And reading stand to ensure that from shorter distances, she doesn't develop like what she said, somebody having neck pain and other things. So postulated issue should not be there. And for enhancing the contrast, you can suggest a reading lamp. You can suggest in place of HB, you can go for 4B, 6B darker pencils that will help her. Next. So there are multiple visits. I'm going at say 4 years later, what happens? So new activity limitations are getting added here. So now the board work related problems is there, but what has happened is the earlier problem was from second row, first row she could manage. Now even from the first row, there's a problem because it's a progressive visual loss mobility problem is still persisting because she is not using the torchlight, task lighting, whatever you have suggested. So young kid using it, parents are not, they were always escorting her, making her dependent on, and differentiating colors, difficulty seeing in bright sunlight, which means glare issues she started reporting, reading small print in textbook, even with her spectacles. So at younger kids, if you think of 10 years old, they'll have ample of accommodation. They can manage at shorter distances. And if they're myope, they can take off glasses and read it. At times, the contrast level, the light levels in the classroom may not be sufficient when it is cloudy outside. And if they are not using, they may have these issues. They may report occasionally they are having problems. So we need to identify where exactly they have and then accordingly suggest the solution. And for color adaptation, what we usually recommend is if it is say identifying the color pencils or so, labeling it. Somebody who's completely colorblind also, they can label it and that way they can manage. If you see the acuity has dropped from 2050, 2060, now the best corrected acuity has come to 21, 25 in each eye. And if you see low contrast acuity also earlier, there was a 1-line difference here and you see 2-line differences, which you are seeing in the right eye, 1-line difference in the left eye. So that line difference, usually people look at it, but recently in our research, which is, we are looking at different age, if you look at because of the vision development process, the difference in the high contrast, low contrast acuity, that is not actually the correct parameters to look at. So we should know age appropriate norms of contrast sensitivity to compare and then interpret these results. Binocular near acuity was N6 at 20 centimeter, but despite this, she had problem with the difficulty with managing things. Go to the next slide. So best corrected acuity 21, 25 each eye. Next one, please. So we thought, why not give a trial of telescope? Everyone suggests distance task means telescope, standard 4x telescope. We expected that probably that will work, but she could not manage with it. So we thought it could be because of the field loss. It could be because of the general reduction of sensitivity in the visual field loss. Go to the next slide. So if you see in multiple occasions, it was done, low test reliability, it is showing high fixation losses, it is showing, which is not uncommon to see in young kids because that is a natural way when you are not able to see things and you're performing a test you want to pass. So you will scan and then you will try to compensate. And that is a natural mechanism when somebody is having tunnel vision, that they'll be scanning and then they'll be trying to compensate. And that is why these fixation losses, unless they understand and you get the reliable fields. For glare issues, we tried multiple filters. So again, Neuer filters and different shades are available. Her preference was medium gray filters. And as she said that specifically in patients with RP, if you have issues with the delayed adaptation, you might consider giving separate tinted glasses than combining and giving them photochromatic lenses. If they do not have delayed adaptation, you can consider giving them photochromatic for the convenience, because for children at times managing two separate pair of glasses will be difficult. So then, and if you are giving photochromatic lenses, you may also guide them that because you know that latest, which is 8th generation photochromatic lenses or transition lenses which are available, they quickly adapt, they quickly change the color. Go to the next one, please. And for reading, yes. So because for distance, it did not work out, telescope. So what can be considered? So electronic magnifiers, which you have seen for working for the near, there are some of it which can work for distance beautifully. You can change the magnification, contrast, and binocularity is still possible. So even if people have tunnel vision, they can still manage with it. So we tried a multitasking video magnifier, 5-inch, 7-inch screen, and she found it useful. We also gave her an option of trying using a tablet computer, which is iPad. And she found it very useful because she could do multiple other things than magnifier. Magnifier only allows her to read and makes her feel like a disabled person. This makes her look like a tech savvy. Go to the next slide, please. So medium gray filters were suggested. Computer tablet was suggested for managing reading fine print as well as for doing her board work. Next slide. So she has been regularly following up, but in this visit, what happened in 2017, she was observing cricket match happening, and then cricket ball hit her right eye, developed RD. It was diagnosed in another hospital, and she came here for second opinion, underwent RD surgery. After a month, again she came. There was a significant vision loss. Next. And now she's still using her computer tablet. It is helping her, but she faces difficulty reading small print. She says at times it is hard for her to manage. Go to the next one. So if you see, gradually her vision is dropping from 2050. Now it has come to 2400 in the right eye, which underwent RD surgery, and the left eye is 2200. And significant loss in the contrast sensitivity, near acuity is N10 at 15 centimeters. So this is not suffice at this stage, at this class, because as you see in the primary sections, print size is much larger. As you come to the middle, higher schools, print size becomes smaller and smaller. So demand increases, the duration they have to spend. So even if they're making use of accommodation, sustained reading will be difficult there. So that is where introducing magnifiers are helpful. So here, and we calculated magnification requirement based on the EVP. Go to the next one. So when you're calculating magnification, we don't keep the target as it is. If somebody wants to read an 8 print, we don't target for 8, we target for 4. You keep 2 to 3 lines under reserve. Like when you're correcting presbyopia, you always think of keeping 1/3 in reserve or half in reserve, something similarly. So because it is known that people at threshold will be reading with 50% accuracy slowly. But for fluent reading, as you increase the print size, you see that accuracy speed will improve. And usually the critical print size is almost double than so that ratio of 1:2 provides you fluent reading. So that is the reason N4 we targeted. Go to the next one. And you get the best corrected near acuity was recorded N10 at 15 centimeter. Target you kept N4, and magnification requirement number 4.1 X. So we tried in the similar magnification 16 after LED stand magnifier, assuming that RP person having RP may find it useful. We also compared it with the video magnifier. Certainly, you would see the difference here in the field of view, there the field of view, the contrast. It is as expected that person will prefer portable video magnifier. But she said that that much she can do it with her tablet computer also, but she has to get every book scanned, uploaded as a PDF. Then also she can zoom and manage. So why have a separate one? We'll continue with the same thing. They got the concept. They said they'll continue the same for distance as well as for near. We also suggested, because for prolonged reading on the screen, at times they may complain of eye strain, burning sensation, fatigue, which most of the people or IT professionals complain. So we suggested audiobooks as an alternative for, so she can have a combined approach wherein she can use some duration audiobook, some with this. Next one. And these are the examples from our study, in-house study, wherein people who were using computer tablet, what was their feedback. So as you can see that how and why did they prefer, okay? So I prefer to use iPad because it serves multiple purposes, that I can use it for reading, watching videos, and accessing the internet. With a video magnifier, you can just do one thing. Telescope, you can do only one thing. For near, you have to use separate device. Go to the next one, please. So this is in 22, 1 year, 2 years back. So she completed intermediate. Now she has to use computer, and that's for higher studies. So parents say that she's not able to use computer. Difficulty in going around unfamiliar places, because this is stage for how long parents will assess. So they expect now she should be independent to go to college. How will she go? How will she manage independently? So therein they were really concerned. So we had to provide, and at this visit, we also, because they came with the sibling saying that sibling is also having similar problem, younger sibling. So if these were identified earlier, probably we could have helped prevent these situations. So genetic counselor had assessed them, identified that yes, it's a consanguineous marriage. The sibling is having similar problem. Okay, next one. Visual acuities have significantly dropped from there, and then refractive correction was making some difference, not to the extent which they wanted. So audiobooks, iPad she's already using, an LED hand magnifier, because she has looked at it. She said it's not useful, but from somewhere locally she got something for spot viewing or something like that she was using. Go to the next one, please. So these are the refraction values. Near acuity still remains same N32, which means she can just read the headlines, sub-headlines of newspaper, not the small print. Next, please. So same video magnifier. This time again, we insisted that an alternative to iPad and other things is because there and again adjustment and all those things might be difficult. Spot viewing is possible, scanning those documents. If you want to use for longer duration, different books which are not scanned available, video magnifier is the solution. And even in the examination hall, this will be permissible for her to carry if she wants to read herself and write. If she was happy using a scribe facility, it's possible. So for computer, because here in at this level of impairment, magnification doesn't help. So screen reader improves their ability to do things faster. So she underwent use of NVDA, and she completed it on 21st September 22. And these were the different programs which she learned. Go to the next one, please. If you can click here on this video. Yeah, here.
In the final of the women's singles event in Switzerland. The world.
No problem, I'll describe it, what it says. So this video is showing a specific application just called ADDA, ADDA. It's an open source available for current affairs. You can just pause the video, please. So it is for the current affairs. So persons with visual impairment, they can just listen and learn about it. For the competitive exam, if they have to prepare, they want to learn about general knowledge. And then there's a keyboard application which converts text to speech. You can just play that. And so you see that she's capturing it. And it will scan, upload it, and OCR-based system will identify and read out for the person. And it can do for multiple languages. But sometimes people find it difficult, inconvenience that every time using mobile, can I have it in the glasses? And that is where I think smart vision glasses help. So smart vision glasses do pretty much same thing. It's a wearable device using similar applications combining together. Go to the next one, please. Next one. Next slide, please. Next one, next slide. Yeah, if you can play here. So this is showing the magnification app display here. So you can see that way things get magnified. Okay, so Windows and plus, these two commands, if you tell them that, okay, Windows along with plus, if you press, it will magnify the number of times you want to magnify. There are simple commands for enhancing the contrast, reverse polarity, and people can still access. Go to the next one. So people having mild impairment can use of magnification. People with severe impairment, advanced field loss, screen reading option. So here and she is using the screen reader.
एड्रेस बार जाने के लिए और जीमेल अकाउंट ओपन के लिए कुछ शॉर्टकट्स है। मैं शॉर्टकट यूज करके जीमेल अकाउंट लिखी हूँ। मैं अपने अकाउंट यूजर अनदर अकाउंट जाने के लिए मैं टैप की यूज करती हूँ नेविगेशन करके। यूज अनदर अकाउंट आया, यहाँ पे अपना ईमेल आईडी लिख के लॉगिन करूंगी। अभी पासवर्ड लिखूंगी लेकिन कुछ बोलेगा नहीं। Enter your password edit. Gmail dash inbox. ऐसा मेरा Gmail inbox open हो गया।
People can download on their app, on their laptop computer and can, but yes, they have to learn how to be familiar with the use of keyboard and then make use of it. So for that, there is a 3-month structured training program which we provide at our center. I'm sure here also they have initiated. They have, I think, 3 computers, so 3 systems, and you're having a dedicated person available to provide training in Pune. Also, you have that facility now available. And these are some more apps. If you see, people can use those TalkBack application to access Ola, access Big Basket, all those things for shopping and other things. And Be My Eyes, another one. If you just go to the next one, Be My Eyes, if you can play it. So here in a
My eyes. Please wait. Be My Eyes. Using rear camera, please be my eyes. End call button. Tap to activate.
Hello? Hello?
Hello,
Hello?
it's Maggie Masala.
It's Maggie Masala. Thank you, sir. 1 second. This one, sir?
It's Amulya Dairy.
Okay.
Yeah, it's I think tea.
Okay.
Whitener, it's whitener.
Okay, sir. Thank you. 1 second. This one, sir? I have to know.
It is Everett's masala.
Okay.
Okay, so there are certain things wherein application can read out, certain things wherein you feel that no, application may not read out or may be difficult for application if I want a sighted person to give me feedback. So those people who are registered from whichever place they are registered, they using the camera of your phone, they can help you assess, identify the color, identify those things. Okay, go to the next one, please. So as we see here, in the change in acuity has happened, person started the mild impairment, then moderate, then severe impairment. The management plan has changed, which means the regular follow-up along with consulting an ophthalmologist. So every time when she comes, usually she has combined appointment. She sees us first and then we dilate and send her to retina specialist so that they can see and they can advise whatever they have to suggest for them to maintain it, or if they have to get some guidance about what is latest available, when latest treatment will be available. So to understand those aspects, go to the next one, please. So from this long case, what we learn is the importance of follow-up, as there is a change in the acuity in some cases, even if in some cases acuity may remain same, but their rehabilitation goals might change. So for that reason, periodical follow-up is important. Utility of electronic devices in specifically patients having severe impairment, and education about genetic nature of disease, and then what is the implication. So even if we do not have a gene therapy, but it can help them understand the prognosis of it, the relevance. Next one, please. So this is the longest case. I think that we have a couple of cases. Go to the next one, please, quickly. So see this child, pretty familiar. Most of the people are familiar with this. And earlier we identify it is better if you see when we saw him at the age of 4, these were the acuities which is recorded. At times, if you look at the values of refraction is much lower, people would think, should we correct, should we leave them? And child is not responding, is not telling you that if there's any improvement or so. But what is important to look at is in the future what has happened, because we provided correction. If you leave it without correction, it may lead to meridional amblyopia. If you correct them early, you may see there's a acuity improvement over a period of time. So person has been coming almost every 6 months to us. Go to the next one. And the other thing which if you have observed, click next again. So next one, please. Next. Yeah. So if you look at here, the initial prescription was symmetrical, but here and you find an asymmetropy of about 2 diopter. So with very young kid, at times they may not have patience to cooperate, and then person may get biased looking at one values and then writing symmetrical values. But when they are cooperative and you have done the assessment, you find there's a difference. Initially, we thought that was probably incomplete cycloplegia. We are finding differences, but we got a scan done. You see that axial difference, and 20% of the cases with albinism, because we have found in the literature, 20%, which means 1 out of 5 will have an asymmetropy, which will be axial in nature. So getting axial length done, recording it appropriately. If you provide the appropriate correction, you'll see appropriate improvement or proportionate improvement, because there's some component of amblyopia which is there because of high amount of astigmatic error. Usually it's with the rule, usually it's corneal in nature. If you do those topography, you may get it and you may be able to correct it, and it helps. So even if there's no immediate improvement, because in the developmental phase, correction of these things might help the person. Next one, please. Similarly, if you see here, somebody with the 2600 presenting acuity adherent glaucoma, phakia. Next one. Using estimation techniques, applying whatever techniques we know about application of just noticeable difference, topography, and other things. You did it, you found some improvement there. So from 2600 to 2160, what difference it brings to the person in functioning, and the magnification requirement, if you're thinking about any magnifier, in terms of when you're certifying people that visual impairment for 600, what percentage will come here, what percentage will come. So it is so important to do that. Next one, please. So if you look at the guideline which government has given for, next slide, please. So use of these estimation techniques, so people should apply these techniques, because in auto refraction will show just error. So unless somebody has mastered the retinoscopy technique, has learned about subjective technique in these patients, stenopic states and other things, it will be difficult for them to find out that kind of and correct it, this kind of cases. Next one, please. So here, in what is important points which are there for you to note. One is the guidelines which is given for the right eye, left eye, or better eye, inverse eye. The other thing, if you look at here, when you are certifying, visual acuity line should be read completely, not the parts. So when people write 2060 parts, 2080 parts, it is difficult, because 2060 parts makes person ineligible for the certification. 2080 makes them eligible. So if person has just read 1 letter, 2 letter, please don't write it unless more than 50%. If we consider consistently everyone works on the same place, more than 50% is only considered pass. That is the thresholding. Then we'll be able to do justice, and everyone will find, otherwise you'll have inter-observer variability in the acuity. And then percentage of disability will change, and people's benefit, what they may get. Some ineligible patient may get it, and some eligible patient may not be able to get it. So it's so important. Next one. Next. This is reported in the literature as well, that when patients, and this is from low vision clinics, when people have looked at ranging from 11 to 27% of the patients, categories of impairment have changed. More than 2 line difference. 1 line we consider test readers variability, more than 2 line difference has been observed. Next one. This is another person with albinism, consulted a low vision clinic locally, was prescribed plus adaptive spectral magnifier with Bayesian prism, which he was using for working on the system. And he said it causes headache. I can read it, but I can't prolong. Reading is difficult. And when we did assessment, we found dry refraction showing significant hypermetropia, giving little addition, which comes very close to it, appropriate astigmatic correction. He was happy with this kind of correction. So we gave intermediate correction, showed him and gave him some adaptation time, see if it works out for your computer work. He said, this is much better than my. So at times overdoing it, we prescribe spectacle magnifier with Bayesian prism without thinking Bayesian prism is required, not required. So may cause problems. So under cycloplegia also, we verified if you are missing out some latent hypermetropia. So even if person is 35, don't think that they'll not be accommodating. Do cycloplegic refraction if you're finding so much of difference in their current prescription and what you're observing, and then they said based on this. What is another important thing? Don't look at the age when you're giving addition. Often opticians comes back that 35-year-old, is it correct you're giving 2 addition? Okay, so it's not as per the age, as per the need. Please go to the need. And for the reading, like what my colleague told you about the VZoom app, Android phone has it. So for spot reading, we suggested him use this, wherein it works like a video magnifier. You see the print size has been magnified by 4.4 times. You can change the contrast and other things. Next one. So this is by Susan Lead. and their work group has worked. They found 86% of these patients who were pre-presbyopia, even including children, because they don't read at 40 centimeter, they read at 15 centimeter. So they're not able to provide the required, and then their reading performance improved with the addition. So in patients with low vision, at times presbyopia, you may consider sets in early. We may need to consider addition early. Next one, please. Often people have that question whether this will be allowed, this magnifier, can the person use it? There are guidelines. People can find out from the Google, give it a copy to patients so that they understand that these devices are permissible in the classroom along with the valid medical certificate and recommendation. Next one. These are the things which are known fact, nothing new, social stigma, fear of loss of job. If I use devices, whether people will allow me or no. Okay. We understand it, we accept it. But as a professional, how can we counsel? How can we offer them that they don't need to be worried about? There are guidelines which mandates it that nobody can discriminate. Nobody can say that you cannot study in this school. You cannot continue a job. If they do it for that discrimination, they can be behind the bars. Go to the next one. This is from one of the professional, which is very painful. When I saw this patient wherein we were providing low vision care, he was in the mainstream school, got selection in Navodaya Delhi. And father came crying, saying that doctor has certified, no, he's not fit because of visual impairment. He has to be in special school for the blind. So we had to write it again to the board, whosoever was deciding, getting our retina specialist sign, 3 people signing it and saying that child is still in Navodaya Vidyalaya studying it. But as a professional, we have to realize that yes, using magnifier is safe. Day in, day out, we are using it, right? We use slit lamp, we are using 14 times, 16 times, 40 times magnification. If it is unsafe, then why are we using it? If we can use it, why can't my patient? Next one, please. So these are the things strategies which we use, dispelling the myths which are related to use of magnifier, use of light, short working distance, appropriate refractive correction, magnification as and when required. Only 10% of the patients may require. 90% you can manage without magnifiers. Scanning, eccentric training, environmental modification, sensory substitution in patients with severe impairment. Every case magnifier may not be successful. We need to consider screen reader and other things. Audiobooks and other talking books are the examples, talking watches. Next one. So if any questions, I'm happy to take. If I
Reading at a closer distance, these children did not develop statisma.
for that, what you do is you give basin prisms if it is required. If it is there's a difference in the visual acuity in both the eyes, more than 2-line difference. Usually binocularity will not exist, so they may not be. It will be monocular use, so it will not affect them. They would have already learned suppressing the other eye.
About the ARFD. There are irons that are available who have been within the tire, specifically made for dry. What about the results about those irons in India?
I have no idea, sir. I have heard about a couple of case reports wherein people implanted telescopic lenses, miniature telescopes, which were implanted, which gives about 2 times magnification. But then we have to also think about if you're implanting telescope, the risk of glaucoma and long run other things. They have to also think about in this patient about the space orientation, the depth orientation with the magnification, with the magnifier telescope or anything. People can visualize better. Yes, acuity may improve, but it may not help them go around. So mobility gets affected there, and for the learning to the new visual environment may take longer. And unless they have been given that trial before, what will be the outcome, fixing something, how fair it is, I have no idea about the ethical consideration about those things, because at times people have those surprises and we have nothing to do with that.
There was one Israeli company who came with these telescopic lenses could be implanted intraocularly, but that required a larger incision because the device was very big. And they were giving samples to us to use them. As Dr. Bajaj said, it is very bulky and difficult to put in the bag. So, what is the use of this? Is it because of the size of the lenses? Or is it because of the size of the device? Or is it because of the size of the lenses? Or is it because of the size of the device? Or is it because of the size of the device? But it requires, we have to have a proper selection of cases also. If you have a large central scotoma, doesn't work at all. Idea is to have a parafoveal fixation happening in the with the reflective effect. Your fixation changes into parafoveal. But if you have a very large scotoma, it doesn't work out. In recent times, they have a new designs and lenses, which optics are modified a little bit without having a prism back, but it has an effect like a prismatic, which shifts the fixation to little eccentric to the area. So we have done some study, those lenses are made by a care group in India also. So we had done some studies on those lenses, which are made by a care group. So they were like a simple designs like Acrysoft lenses design, but it has the modification of, getting the right ratio to fix a little paracentral. And it did increase the magnification a bit because we put little higher power in these cases. And we picked up those patients where we had a, scrotum which is slightly smaller. If you have a larger scrotoma, more than, 60% involvement, we could not improve that. So we had some improvement in these cases with one, we picked up a patient who had some sort of cataract also. So as such, their contrast improves and the vision improved a little bit. But it was a 9 or 10 cases only, so we could not really comment on that. If you have a larger number of cases, then we can talk about these. Otherwise, these lenses have been a futile exercise. I've used 2 of those telescopic lenses. Nothing happened in those. I had to explant those lenses subsequently because it was causing glaucoma, as you said rightly. And one patient had a very significant corneal decompensation because there was hardly any space for those lenses. So difficult, but I think in future there'll be some modifications.
Can I add a point here? Yes, sir. Yeah. So there are 2 aspects in which we should be very clear in. As a clinician, we look at the acuity improvement. Always we look at 20/20 as our target, right? But is patient looking at 20/20 or patient looking at the functional improvement? So if the goal, because in rehabilitation, we are just looking at their functional aspect and what are the alternative methods, what are the safer methods, and we discuss with them and let them decide what works best for them to continue functioning. Because we say acuity improvement, visual field improvement is not, and that is, I think it'll not be the correct thing to say, because at times students will ask me that it's improving from 2200 to 2050. I know a telescope will improve 4 times, 5 times, depending on the magnification strength that I'm getting. Is that the purpose? How will it help the person? Can he walk around with that? No. Because the field of view that you're getting with the 4x telescope of 12.5 degree, you can't do much work. So unless somebody has a specific task that I want to read something on the board, so they have to have that specific task, the specific requirement. So whether if there's unless there's a felt need of functional limitation, we don't need to intervene probably. We may need to just counsel them, guide them. Yes, so it's not for the acuity improvement. So that is where at times people go dissatisfied when people are dispensed a magnifier when it was actually not needed. They may have it, they may would have purchased it. And many countries wherein it is covered under insurance, they are given multiple units without knowing the use of it, utility of it, because it's covered under insurance. Here and because people have to buy off on their own. So after trial training, they'll let you know that they find, and we find only 10% of the people find it useful. There also 25-30% of the people may end up using it. Some people will come back and say that we're not finding it much useful. So compliance is not very great. So that is why we try to manage without magnifiers as much as possible, even if we tell upfront that these are the problems which we are also seeing it, but these are the ways you can overcome if you find it useful. So once they buy it, once they buy the idea that yes, it will be useful for me, compliance is much better. Thank you so much.
Thank you. Thank you, Dr. Bagga. Thank you for that wonderful presentation. I know you have a flight to catch, but if we can just quickly have Mr. Ramu sir. Ramu sir is from the SHG group. They are the makers of the smart vision glasses, which may perhaps revolutionize rehabilitation as we think of it. So over to you, Ramu sir.
Thank you so much. So before I just want to show, yeah. Okay, okay. Okay, I'm Ramu Mutangi. I'm an engineer by profession. Okay, and design of things is close to my heart. Okay, and when there is a problem, then we try to solve. And all my life I was working on the products. Then why I started working on this, there were two reasons. Okay, I just wanted to show you that. One was, the primary reason was my sister, my elder sister, very close to me, and she had diabetic retinopathy. She didn't even realize that she had diabetes. She was in self-denial. All the time she was saying, no, I don't want to go to a doctor. I don't want to go to a doctor. And then when she was diagnosed with this diabetes and she was put on insulin, she was 72 or 70 at the time. And then one day I noticed her walking very oddly, very, very odd. And then she used to shoo me away. Don't bother. How do you care? Then I found, I took her, I dragged her to an ophthalmologist. And what he told me was she didn't have vision on her left eye. Her retina got detached. And on the right eye, she had just 10% vision left and she was heavily cataracted. And he told me, if your sister can get her sugar levels down below, I'm not supposed to touch if it is about 200. And even I can take a risk and 240. A very good friend of mine who lives in our community. And she could never make it. I mean, she passed away due to multiple organ failure. So I started working on this. And I do not know much about, actually ophthalmology or anything like that. But what we are trying to see is when we meet people, we see their problems, the actual physical problems that we see, and then try to find what could be a technological solution for that. Okay, today I have with me the devices that we made, and then the journey we made so far. And also, we are also trying to make one device for low vision. That also I just want to show you. Won't take too much of our time. And I'll just go to the next one. Thank you. So this is one picture that, I mean, look at the children, look at their hands. There is nothing in their hands, nothing in their hands. This is the situation of most of the blind schools, not only in India, but all over the world. Why I say all over the world? I know the blind schools of the special needs schools in the US. I live in the US, and then my wife works for special needs children. Okay, and then there also, all textbooks are not Braille coded, and then only 2% of the world's blind population know Braille. And when you see them, they don't have anything in their hands, and then what they hear is what they learn. That is the state of children. And then there are 1.6 million blind children in blind schools. And you look at them, if they have 40 years productive life ahead of them, we can add easily 64 million productive years to the GDP. So when we started working, I got a lot of encouragement. One encouragement I got from Vision Aid. Vision Aid, like, we made a device. We made a device, okay, and this is how it should look like. Then it was it's a prototype I made. And then I was looking for connects because I don't know many, I don't know many doctors because here in India. And then I just called, one day I came across Vision Aid. Vision, this is a story I need to tell because I'm most grateful to Ramakrishna Raju, and who said, I just sent it was a cold call. And he called me back. And then I said, so look, I want to know more about this because we work in the area of vision aids. So I want to know more about your device. I described to him, and then he never met me in his, he didn't even ask me, show me your device or anything like that. Then he asked me, so look, we do give vision aids to the blind children. So what does it take for you to start manufacturing this. I'm a good engineer, but very bad businessman. Okay. And then I said, I quickly made some calculations and all that. I mean, which went completely wrong afterwards. And then I said, okay, Ram, I may require about $120,000. Will you be? Within a week, I got the check. He said, okay, Ramo, but I'm going to put conditions. Okay, I want you to make sure that your product is usable by the actual visually impaired. Can you give that word to me? I said, okay. I'm a little bit overconfident when it comes to those things, but I had an excellent team. I have excellent team who made it happen. And Devi Uday Kumar is one of the person who started helping us. Then afterwards, he made connects to me. One was Dr. Scott, doctor. And then I spoke to you, doctor, and he wanted me to talk to you. And then he introduced me to Dr. Vijay Lakshmi at Arvind Eye Hospital. And Dr. Vijay Lakshmi and also LV Prasad, LVPEI, and Dr. Baga's team. And like that, he started connecting me to various people. And then we made the first one. Dr. Vijay Lakshmi evaluated over 8 months. And on 100 patients, she said, okay, this is usable. I can take it. Okay. But I mean, like then the journey started and we are in a good position. We are self-sustainable. And then also we are working for a good cause. And at the end of the day, like, you see, you help so many people and you get good sleep. And then my team, a 30 people team, very young team. And then other day, someone asked one of my engineers, what makes you, like, Titan I Plus people came to my office. Okay, they asked one of my engineers, she was describing about what she's doing out of this AI, artificial intelligence, machine learning. What makes you stick to this company, which is not known to anyone? She says the kind of satisfaction I get out of my work. And also we also participated in one innovation contest by Infosys Foundation. Mrs. Sudhamuti, she thought, like a lot of people are working for the social cause, but what they don't have is the money. I want to have a contest and give a good prize money. And then this year, 2023, after COVID, she ran So this is the journey that we had. When we started in November 2020, when we sent it to Arvind Eye Hospital, so it had two hardware on both sides of the glasses. Like, it has got the processor, the camera, processor, vocoders, everything, battery and everything. But children could not wear it for more than 10 minutes. They said they felt it very heavy. And they said, okay, they would just take it away after 10 minutes. So then we came out with the second model, which is now, most of you have the second model with you. So the third one, that is, we are launching in June 24. It's already there. I want to show you this. It is much smaller. No. This you can see, this is much smaller, and this is wireless. This is wireless, and also we have increased the, I know it has got a camera. Camera is for just the equivalent of your eye. And then we also add a device called a LiDAR, light detection and ranging, that is used in your driverless cars. Okay, and then this is a small component. Driverless cars use dynamic LiDARs, which are much bigger in size, but this is a very small one, which tells me that the obstacle about 4 meters away. So that we added, and there is a flash. Flash is true because visually impaired children wouldn't know what are the light conditions like, so they try to read in darkness and all that. This will provide light for them. Okay, and then here we change it to swipe. So when I swipe, it tells me things around me. And then I tap it once more, it starts describing me. Like, it can tell me the beautiful flowers and the colors of the flowers and the suits you're all wearing and the ties. Because this is not we are doing. There is a lot of research being done by people like the giants like, Google, Amazon, Microsoft. And earlier, Doctor, I was only telling what are the things around you. But today we added Gemini. Once with adding of Gemini, so it can describe the surroundings for a visually impaired person. So that one. And then also earlier we had only and the second one is the read. When I say read mode, it reads the text in all the languages. It supports all the Indian languages like Marathi, Gujarati, Punjabi, Bengali, Malayalam, Telugu, all Indian languages, in addition to English and Hindi and other foreign languages. Now, with this particular, what is called regenerative AI, we also added, if there is an illustration on a page, it describes. Suppose there is a tiger, it talks about tiger. Okay, this is very useful for the children who are in the schools. And so those are the various features. And also, one more thing, today, if you see any blind person, when they want to read anything, they just take out their mobile phone, keep it very close to their ear, and then put a talkback feature, and then try to read their messages. Today, you don't even have to take that mobile phone from your pocket. I can say, read my mails, it reads. Or read my WhatsApp messages, it gives. Sing a song for me, because these are all available. These are all available, and we are making it available to the visually impaired people. And then we are trying to make that, that they have to get used to this kind of a life. Okay, so that's the thing. And then the next one we are going to do, what we are planning to do is, like today, it has got a dongle, but we want to come out without the dongle. Like, it should look like because to all said and done, they don't want to be seen with an assistive device like this. They don't want to be seen with a dongle because they don't want to look odd. They want to look like anyone else. So we are coming up with this glass, which is embedded electronics in the temples. Okay, this is just a prototype that I brought. So they should be able to put it, and then, they should not be conscious of what they're wearing. So this is the thing. So this is the journey that we are making today. And again, but for the encouragement from doctors like you, and also from people like VisionAid, and so many of our other organizations like HTBF, Help the Blind Foundation. Again, Help the Blind Foundation, they blindly believe us. Okay. We want to improve this feature. And he knows because you will improve the feature, I am coming to you. I know you can do it and you do it. That kind of trust they have in us. Now, with all the encouragement, we are coming up with another device because we got to know more and more about while dealing with all the beneficiaries. When we go to all the patients, and we got to know that there are a lot of people who have residual vision, like low vision. So we are coming up with a device. So this device, I'll just show you. I'll hold it after, no problem. So this device has got, these are VR glasses, virtual reality glasses. And then you get a huge screen in front of you. And then they have bird bath glasses. And then you can also use pancake glasses. And then you have a prisms. So you can see almost 100-inch screen when you see. And then what we have put here is a camera. I put only one camera now, but we are going in for 2 cameras with different FOVs. Okay, and so that we get this gives about 5x magnification. But once I put second camera and then adjust the FOVs properly, we can go up to 15x magnification. In addition to that, we can also, what we do is we take that view from the cameras and then multiplex and send it to our mobile phone. And then on the mobile phone, since we have the picture with us, we can do whatever we want to do. You want to either magnify, because our this thing is to characterize the vision of a patient and then adjust the image, and then whatever is there, the image that you have done, and you mirror it onto the large screens so that they can see it very, very clearly. Okay. I have few, I don't have, I'll just go to the next slide. This will skip it. We'll skip this. We'll skip this also. Yes, I'll play this.
Over 400 million
again,
people
this
are
is our own
categorized as moderate to
imagination
severely
of things.
Over 400 million people are categorized as moderate to severely The remaining of these, just over 40 million people are blind. The remaining over 300
I think there's some problem. Okay, so we'll go to the next one, if you don't mind. Okay, this is, of course, you might have seen this already. We'll skip, and we can see it shows.
And those sensors will use AI, artificial intelligence. So Google Pay, Pay. So we can do a demo if the judges can come on stage. उनका face recognition हम कर सकते हैं.
Of course.
Kumar son with a mustache. Onish Bass standing in front of a large stadium.
हाँ, stadium में बोल दिया. इसलिए है ना ये frame में all these and those sensors will use AI.
So we'll skip this. So this is just the technology behind the whole thing. Then we use a burst Wi-Fi, and we have a patent over this technology. We'll go to the next one. Next one. Next one. Yeah, this is my team. I just wanted to show you. This is all young team, and so these are the people. I know, like I can't really describe the kind of energy these people have. Okay, let's go to the next one. Here are my Dr. Vijay Lakshmi. She's my, and then Dr. Manjunath. And Professor Paul Raj is my guide, who's a professor emeritus at Stanford University, my guide, philosopher, and mentor. And I'm the CEO and the CTO of the company. And then we'll go to the next one. Yeah, we'll go to the next one. Next. This is okay. This David, this is yours. Okay. Yeah, this is what we are trying to do. So like, when you have the central vision loss, how we do is we capture the stuff and magnify it in such a way so that spot moves to one of the corners. The next one. And same thing here. When you have a peripheral vision loss, what we do is we capture the complete image and pan it in such a way that it is visible to the area that, so you can see the whole thing. Yeah, we'll go to the next one. So these are the various things, wide view, zoom view, and reading mode. In reading mode, we can put multiple stuff. We can do reverse video. We can do, select the area you want to see. And then also for the people you still can't read it, then we can use OCR. And then you'll be able to read the portion where it's blackened out for him. It'll detect that he cannot see, and it'll read out to him in his ear. That feature is also we have put. We'll go to the next one. Yeah, we'll go to the next one. Yeah, this is reading mode. Next. Yeah, and then just a reading. Suppose someone wants to know where he wants to read, he can put his finger, so it starts reading from there. It can magnify the stuff. And then also you can say which area you want to be magnified. And you can ask for the spell word, window magnifier, whole lot of features that you can. So all these things are possible because this is not this all already, the whole lot of research has been done in image processing. So what we are trying to do is we are trying to pick up some problem and then trying to see what we can do. Yeah, I think this is pretty much like this is how it reads. You can go in for, we can go to the next one. Yeah, and we can also know that for color blindness also, we can play around with the colors. Like whichever we can also sense which wavelength, particular wavelength that the person is not sensitive to. And then we can go and then saturate the other colors and move the colors to another spectrum. We can do that. We can do, yeah, we'll go to the next one. So this is the way we colorblind adjustment modes. It's different things that we try to play around with the images. Okay, this is a blurry and hazy vision where we can sharpen the image for them. And there are some people who cannot, we can do the reverse video also. We'll go to the next one. Okay, I think that's okay. Yeah, thank you very much. So what the kind of, thank you. The kind of help I need from you, doctor, because we do not know. We do not, like, and personally, I do not know. I'm supposed to be the CTO of the company. I'm supposed to lead the young team who just do not understand. Today, we are picking up our knowledge from people who come to us. But my request is, if you can guide us, we'll do it for you. We'll do it so like the people you are trying to serve, the visually impaired people can benefit a lot. So that's what I want to request you. So I need help. I need help, from the point of from the, what do you call, I don't have the right word to use. Technology, we can always struggle and get it going. But the actual, what the patient actually feels and how we can improve and whether we can see the outcome that you can only suggest. That's all, doctors. Thank you. Thank you very much. Sure. Yes. Yes. No, not really, doctor. See, I have a Ray-Ban glasses. I have one. Yeah. Trailer. Okay. And then what they have introduced, I got it. Last month I got it I was in US, and then I bought one and then brought it here. That is not for visual impairment, number one. That is for lifestyle. Okay. And then the way the Ray-Ban one came in, the Ray-Ban and Meta, they work together because Meta wants to, because the Meta wants, you heard of Google Glasses. You heard of Vision Pro of Apple that's coming. Google Glasses never, they brought out quite some time back. They are ahead of time, but that's not meant for visually impaired. They're supposed to be but they got into lawsuits because of privacy. That you can just control everything from this itself. You can make a call, you can open your computer, everything with with your eye, with eyeball movements. Okay. But Meta, what they want to do is, Meta wants to do, first thing is the lifestyle and the recreation. Suppose I'm skiing or I'm riding. I can't take out my phone and then take a picture. So what I do is I simply click and then it's get connected to, it goes my Facebook instantly. It goes to my Facebook. Yeah, I have taken all these things and then I can say, yeah, I'm on Alps and then here are the pictures. And then it goes to my group that they can do. I said, you can send one single shot or a video. And then you can send it to your Facebook and Insta. That's all. But it's not meant for visually impairment. Yeah. So they're more of this thing. And then you ask me, like, and other people are also, many people are coming where they want to come out with this kind of classes because they want to make sure that, you take a picture and send it. The thing is, I want to take a picture. I'm at so-and-so location, then it's updated on the social media. But for the kind of things that we require for a visually impaired person are entirely different, Yeah. This one, the present glasses cost 30,000 rupees. 30,000 rupees. And then this I haven't priced yet because this way they have a bone conduction glasses. Bone conduction is a little bit expensive. The components costs are more. So it is wireless and bone conduction. It may go up by 5,000 rupees. Because one thing that we started with our goal is to make the most affordable. It has to be affordable, like an affordable device to open up world of opportunities for millions of blind people. That's our goal. And then Dr. Dev Shetty once said, if it is not affordable, it's not a product. So we want to make it affordable. Even this also, I want to, the reason why, like today, we don't make in thousands. We make in hundreds. Okay. We make in hundreds. So the price is not, we can't bring down the price because if I buy components, let's say 100 components, a component which is costing me, let's say 1,000 rupees. And if I buy 1,000, that comes to 700 rupees. And then if I buy in 10,000 rupees, that even drops. It's the economy of scale. So we can definitely bring down the cost if we get enough. Yeah. 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 Thank you. Thank you. Thank you very much. Thank you.
Yeah, that was indeed a extremely innovative and very interesting invention that you have. And I think it will change the way the low vision spectrum will progress in the future. And it will be a big boon for the visually impaired. Thank you very much and congratulations to you and all the best for all the future endeavors. We will have two more talks. I would like to invite Dr. Kuresh Maskati, sir, to give his comments about this low vision devices and the whole specialty in general.
Parikshit has sabotaged it very well because he knows that we are close to dinner time and we've had an exhaustive session. So we will not display the 433 slides that I was planning for. Now it's too late. So this smart vision glasses is something that we have been using. I have a vested interest. I don't have a financial interest. I have a younger sister in Boston who is a big contributor, financial contributor to Vision Aid. And she has come to India. She has gone to Arvind and other places and has helped to set up these places where they can teach the trainers. They're trying to teach the trainers to reach out to the blind and teach the blind. So that's one of the programs. And then she came across the smart vision classes. So the Vision Aid has invested heavily with Mr. Ramu, as you saw. So I am sort of connected. And then, but even then, I had to plead with her because up to now, the smart vision classes were only in the institutes like the Shroff Eye at Daryaganj and at LV Prasad at RP Center and Arvind. So I had to plead with her to that there is a 10 to 15% patients who can afford to pay. They are not all poor patients. So you should allow me to keep these smart vision classes at my clinic. It took about 6 months of arguments. She's a younger sister, so these things take a little time before she agreed. And I said, I will not make money on the smart vision glasses, but we will give it to patients who can afford. We'll make a small profit and then we'll plow back that profit and give that smart vision glasses to those who cannot afford. So we've been doing this for the last 2 years from my clinic. And we thank people like Dr. Nitin Dedia who came on Indian Idol and really promoted this concept. So we're getting more inquiries. So even now at our clinic, that's the Maskati Eye Clinic in Mumbai, no financial interest again. Anybody can send any patient for a free trial. And my optometrist, Hetal Mistry, is here. She gives about 30 to 45 minutes of time and educates the patient and their caregivers. We insist that they come with at least one caregiver. And then we try and see whether the patient is smart enough or has a smartphone or has the inclination to pick it up. So roughly about 1 in 2 patients who come for a trial go away saying that they don't want to use it. So it's not meant for everybody. They need to be a little intelligent. They need to have the little access to technology. They have been perhaps using a smartphone. These are the type of people who will pick up the smart vision glasses. So when you as optometrists are prescribing these, you'll have to actually sit down. Don't just prescribe. That's why I hate it when people go on Google and they say that there is smart vision glasses. Can we order it from SSG Technologies in Bangalore? Yes, you can order it from HSG, but there is 50% chance that you will not use it or you will not know all the features because as Ramo explained, there are so many features in this. In the current model which we are using, which is the 21 model, there are 5 buttons over there. Each button means something else. There is that emergency mode. There is the facial recognition mode. There is the reading mode. So unless they're taught this, unless the training is given properly, just buying it off the shelf or going to Lenskart or Titan Eye and picking up is not going to work with these. So we encourage that in case you have patients who require it, please send them to a center which is dealing with it, where the optom or whoever is dealing can actually train the person, spend half an hour, 45 minutes, and then let the patient decide whether it is good for them or not. The costs come much later. But I agree with all the previous speakers that this is a technology which is here and which is only going to, and I'm so encouraged by Ramu's speech today about the bone conduction and the swipe feature, which is not there in the existing models. At a mere increase of 5,000 or 10,000, I think it will still be affordable. And there are enough charities which are willing to put in money so that patients will get them free of charge. So I feel that we need to reach out to more blind people. And the tragedy is that almost 95% of the blind in India are not even aware of these technologies. Whether they can afford or not is secondary, but they're not aware. So if all of us who've been educated here today and can take this out and in your WhatsApp groups, in your Optom groups, in whatever groups you are, talk about it, even in social parties, just talk about what you heard and read and learned today and sensitize them to that these are involved. that these are available. As I said, all the leading institutions have got these already, so you can refer them there. In Pune, you can refer them to the foundation, Community Eye Care Foundation, so that they can get demos. In Mumbai, you can refer them to me, but more and more centers will come up, and we need to encourage more centers to come up so that this can reach out to the vast majority of the blind in our country. Thank you so much.
Thank you, sir.
The indications are any patient who is willing to try these out, the less the vision they have, the better. So no perception of light vision is excellent. If they have some amount of vision, sometimes that interferes with their ability to grasp this technology. They're trying to use their natural vision and they're trying to use this and they're making a mess. So people with retinitis pigmentosa with very tubular fields, hand movement, 1 meter vision, these are people who really do very well. No PL, no perception of light. They don't need eyeballs. So both eyes, phthisis, absolutely okay. So virtually any blind person who has got some amount of intelligence and who can be taught smart technology and can use this. After training, as I said, at my clinic, which is purely private setup, about 1 in 2 people take or 1 in 3, Hetal? 1 in 2 to 1 in 3 take the glasses. Some of them say, we'll come back to you, and then they don't come back. But that could also be because there is a cost involved. Yeah. About 45 minutes initial training is fine, and then we are always available. So Hetal tells them that if you have any queries, you can come back or you can call on the phone. The other beautiful thing about Bangalore, the SHG people, is that they are also so proactive. So if Hetal calls them up, if there's a problem which she cannot solve, she just calls them up and they provide. Also, the upgrade of the technology comes online, so that on the app which is available, it's a free app, downloadable app. On that app, when they upgrade technology, every patient gets that upgraded technology, even if they purchased their glasses 2 years ago. Yeah. We give it for 40 minutes. If they want to take it home and try it, we allow them to take it home and try it and come back and let us know. Absolutely. The idea is, unless you're convinced of it, then don't take it. At our place, as of now, it's only at a price. But at all the other places, it's available right from free to subsidized. Ethel, how much is the... That flash is there. There is a night mode is there, flash mode is there. But the battery uses your cell battery, cell phone battery. Yeah. There is a camera. Yeah. He doesn't have to see the picture. The camera captures the picture, and using the artificial intelligence, it reads out. It's audio. Patient is not seeing. We are not making patients see. We are making, as Devi correctly put it, we are altering the sensation from visual sensation to auditory sensation. So it is telling you. So for example, I have 1 wife, 2 mistresses. So if I put it on, then it tells me wife approaching, or it tells me mistress 1 approaching, mistress 2 approaching, depending on what I have fed in. So if you feed in names like Smita or Swati, it will give you those names. I feed in mistress 1, mistress 2 because these are dynamic. Yeah, you have to first time the camera captures the face, and then you have to give an input to the. It can keep up to 150 faces can be stored, up to 150 faces, and languages, 79 languages can be read, including all our Indian languages. The other good thing is that the accent is Indian. In the other the cameras which are available, the other smart glasses available abroad, which cost about 5 lakh rupees, the accent is American. So our Indian patients cannot follow these, but here the accent is totally Indian. So it reads Telugu, it reads it in a Telugu language. Telugu, it can read Malayalam, Telugu, whatever. English also, the way an Indian would read English. Yeah. It is. Yeah, it will not disturb anyone else. Yeah. it is in your ears only. Yeah, Dr. Madan. You can, but if you want to use that, yeah, the camera, if you put this on and you keep your eyes closed, it will tell you, provided you have stored those 150, it'll give you auditory clues that so and so person is there. Yeah. No, the patient gradually over time, over 6 months, 1 year, keeps storing people that they want. So whoever they want, you can delete also. You can delete some and as I said, this is my mistress is that way. So delete one, new one comes. See what is happening just now, it is connected to your mobile phone. So it is wired. But this bone and the auditory comes from your mobile phone. But here it is the frame directly transmits the auditory sensation through your bone, skull bone, and you hear. So that is a new technology which is coming out in June. I saw it today at his place. Yeah. Who have nerve conduction deafness. Bone conduction should be available. Yeah. 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 But the primary thing is for visually impaired. Yeah. So, yeah. They are very strongly recommended to carry the white cane because at the end of the day, they are blind. So, in fact, if you put on these smart glasses, the first thing it tells you when you put it on walking mode, it tells you, please make sure your white cane is with you. That's the first line the thing tells you. So it encourages the blind person to always carry the cane. Because other people might not realize that you're blind. Yeah. Okay. Thank you.
Thank you, sir, for the wonderful summation. No, so we'll have a separate special program just for that. And now I would, yes, but he summarized everything, put it in a nutshell. Yes. And Dr. Santosh has liked especially the, what shall we say, the examples that he has given. Yes. Now, I would request Dr. Santosh Agrawal as the president of MOS and Dr. Mandar Paranspe as the president of POS and Dr. Atul Kadane sir as the secretary of MOS to welcome Dr. Titial, our chief guest. So Dr. Titial sir needs no introduction. He is a doyen of Indian ophthalmology. And sir is the chief of the RP Center at the All India Institute of Medical Sciences. He is the dean of AIMS, one of India's finest cataract surgeons. I think he's operated ministers, prime ministers. He's operated His Holiness the Dalai Lama a couple of years ago. And before we hear from Titial sir as the final words, in case Dr. Santosh, Dr. Atul, Dr. Rahul, you would want to speak something, sir, because then after sir is spoken.
Yeah. So first, at the outset, I congratulate Dr. Parikshit and his team for the wonderful session today. They have conducted a hands-on for optometrists. It was also, I visited today, and it was very good. And I think it was eye-opener for me also, because low visual aids is a neglected topic for all ophthalmologists. And so many people in retina, especially comes with semi-blind or blind people. They need this type of treatment. I think today they have highlighted very well. I really congratulate and thank you for involving MOS also. And the speakers we also thanks the speakers for their wonderful lectures. And we learned a lot and we got encouraged. And definitely this new technology, I congratulate you also, sir, for coming out with such a affordable these smart glasses. We definitely market this not in the commercial way, but for the benefit of the society at large. So thank you very much for giving me opportunity. Thank you. One sentence, because you are from low vision.
No, really, these new devices, they have come and definitely they are going to help many blind or the visually impaired people. Now, when we, long back, we started low vision in 2002 at HV Desai Hospital. That time, these all gadgets were not available. At that time, we used to treat patient of low vision with the optical, non-optical devices, only a handful of sets, some magnifiers, spectacle magnifiers, stand magnifiers, dome magnifiers, and the typhoscope and reading lamp and stand, and then modifying the contrast and the glare control and all that, and environmental modification. But now the new techniques, the new technology has come up, and definitely that is going to help a lot of low vision patients. So I congratulate all them, and particularly Parikshit for arranging the workshop. Definitely that will benefit all patients. Thank you, sir.
Sir Titial, sir, if you can please give your words of wisdom.
Good evening, friends. Indeed, it's my proud privilege to be here amongst the top people of this country, working on improving the quality of life of people, of our society. They may be blind because of many reasons, but it is our duty to make them see better, which will bring the happiness amongst the treating people and the people who are receiving treatment. Like to thank Parikshit, my dear friend, for inviting me for this wonderful program of low vision, because that is one area which we are looking forward also. Because as depicted by Mr. Ramu, that we do have a large number of students in the blind schools. And more than that are not there in a school, they are still in their family's home and they are still blind and visually handicapped also. And to have knowledge what new things is happening in this area is also very important. Let me just bring my own knowledge and perspective onto this. Being a dean of research in the institute, I've recently taken over last 6 months. Certain innovations we have done in that area also. Just for your kind information. First time in a government sector, we started the wing, which is called Innovations and Entrepreneurship, which will allow our government doctors to do a research in that area and get a funding from a non-governmental organizations also, which was not allowed earlier. We had to take only government's help in those areas also. And after that, we have now around 9 incubators in AIMS who are doing their research in our innovation wing. And one of them is my own colleague, Professor Radhika Tandon, who has taken up the one innovative work in low vision aid devices. After seeing your model, the smart glasses, we had a demo in the RP Center also, your glasses, and we have one unit there. We are using that also. And this is supported by DBT and BIREC, which is the wing under DBT, which is supporting this research activity of doing some innovation in low vision devices also. And recently, one of my colleagues had gone to through DBT to look into a prototype which is being developed by one Ahmedabad company also. They're looking for similar smart vision glasses also, and that might come in future also. So that is one area of interest for us to look into something which can improve the not only their of way of receiving things. It is not only seeing or knowing what is happening around you, it is your health also is very important. And rightly pointed out, your mental, emotional health is also very important to improve. And that is what is happening with these devices. It's not only the person's ability to know what is happening around him or her, it is improving his physical, mental, emotional status amongst the family members, because it is the family which is ultimately affected by one person being disabled in the family also. Recently, I have worked on this area, how to support people with requirement of glasses. So we are taking a lot of NGOs to support, not only for a low vision devices, which came just now only in my mind. We are supporting the children who require glasses and the presbyopia people who require glasses. Last year itself, the NPCB have given around 9 lakh glasses for children, and requirement is 1.8 crores. So which is like, just a small, कहते हैं ऊँट के मुंह में जीरा. So, like, that's very small amount. So we are working how to get to that level, because we have around 29 crore children in the schools now. And if you see around 15% of them are myopic, that's a large number of students requiring glasses, and that will be changed maybe one a year or 2 years, they require a change. Similarly, we have a huge segment of presbyopia people, not in the city, they are in a peripheral area, they don't know if they require glasses also. And to fund that glasses is also very, very tough for us. So this is a future planning for us. As far as low vision device is concerned, I'm going to work with the Ministry of Social Justice. If we can procure your devices there and give it to our blind people, especially blind schools, that definitely I'll work and make sure we have your demo with the ministry and procure them. I'll take your address also, get you attached to the ministry so that you can present your case there and we can buy, at least few lakhs, so that at least we give it to our schools immediately. And RP Center aims will be part of that, and we'll help you in that direction also. So that's a good thing. Definitely we'll work on, because Ministry of Health will not do anything in this. It is a Ministry of Social Justice will help us in that direction, and we'll try to get funding, if not possible from a DBT or thing, and especially CSIR, I'll get you fund from there also, if possible. So that's the project we'll take and help you in, because this can be done very easily. Because if we have to give around 1.2 million glasses, and if they cost around 30,000 each, it's not a very big amount for the government, and it can be given one time, and you can change the perspective of these people also. The other areas are difficult, I understand, but this is one area. As soon as we say rehabilitation of people, the project goes on very fast. So I'm pretty sure we'll win in this, and I'll take your input and project this to the Justice Ministry, and maybe we get some. Other thing is, in society, we do so many things, and we have to help each other. And that is what I see here. If somebody comes with an innovation, we have to help that innovation to reach up to the people. Because whatever we do, ultimately it has to reach to the person who requires that. If that doesn't happen, then what's the point doing innovation and good work? Good work will only be appreciated if actually helps the people who are at need. And that is very, very important. I think we had a very nice presentation with Dr. Bagga did. One thing, you're sitting here, yesterday I spoke on that. We have now for a medical entrance, there's a reservation for people who are low vision. Your percentage has to be more than 40% to be applicable or to apply for your MBBS entrance. So once they get through this, then you have to make sure that they come less than 40% to be eligible for admission now. There they look for various devices to make them less than 40%. And that can be done for acuity wise. For a person who has a field of vision loss, we cannot improve the field of vision by any means, as we discussed here. Suppose you like to increase the field of vision, your vision goes down further. So that's a difficult area. So we need to look into those areas also. And I don't know how these people will become a good physician in life when they are struggling in day-to-day activities. So maybe these devices, future will have a better AI-assisted devices for these people also, low vision aid people also. And maybe we can make them a better people. So that is a future, and I think we should all work for that area. Make whatever we do it applicable to ourselves and the society. And what is better than making a blind person see? This is one thing when I also tried, as sir was talking about, when the device was in the RP center, I also tried in my head. I closed my eyes and could, appreciate what is being, taught about that. All those four actions were, we looked into that. But we are looking forward to your newer device, which will have more inputs and that will be better also. So I hope that we keep working like this. And you know that RP Center has a national, low vision aid center where we can get various studies done, various things done, and we can help you in that direction also. And this is also supported by Ministry of Social Justice. So that can be done. And thank you, Parikshit, for getting us, and both POS and MOS being here. That makes, I think, things easier for people like them. We can get into the entire society very, very fast and make the younger generation aware that things are moving towards the area where it can be applicable. Not only the cataract surgery, other things are also very important. Thank you again. Wish you all the best.
As you know, Dr. Titial sir is the chief of RP Center, and he's contesting for the post of vice president of AIS. He has not told anything, but on behalf of MOS, we all will support you, sir. We agree. Thank you.
Like, I don't know, like I've come from such a background, for me, it is very difficult to ask for a favor. In my life, I never asked for a favor from anybody. To give a call to somebody also, I feel so hesitant. But to give to anybody, I'm always there, I never say no to anybody in my life. Never said no to, if somebody comes to me for any help, I'm the first person to say yes. Even they come for something which is going to deprive me. Like if I'm holding the, unit, somebody comes like him, I want to leave, I'll say, yes, go. I'll work for you, but you go. But I'm so hesitant. It's so difficult for me to ask for a favor, and that's what is happening across the last few months. But thank you again for all the best.
No, thank you, Titial sir. I mean, you are known as a very, very great cataract surgeon, but as an administrator and putting people together. And if something like this happens, I think, Ramu sir, this will be really great. And your dream of reaching out to each and every blind child in India will be well. So thank you, Titial sir. Yeah.
Dr. Santosh had requested earlier, like the people, coming to RP Center, the students for observership for a few weeks, that I'm going to allow. So we can sit down with your society. We have a society in RP Center only. We call it ORA, that is Ophthalmic Research Association. I can accept your request and we'll get your students supported by MOS. And because we don't have hostels in the AIMS, that's the biggest challenge we have. But I'll give them access to RP Center. They can be there for 2 weeks, see those areas, get acquainted to various areas. And maybe in future, I was talking to Madam Ambekar also. We can have their student also coming through you only, your MOS. And just started, going to start with the AFMC also exchange program. I want all students to go to AFMC to see what is the officially you can become a more like army people working. Effectivity totally changes in the government setup and army people, because I know that we have trained maximum army people in last so many years, and I was asking them, why do you prefer our center? They said it is the difference from army to going to a public area. And the interaction with patients, the type of work culture is totally different. And that's also learning for them also. And I want our students to go to army, have that discipline coming into their work profile. So again, there we are going to start with them also. I think the one thing I've learned going around this country is, getting into some more areas. The one thing I'm going to work is, providing simulators to all the RIUs very soon. If that happens, that will be also achievement for government. Yeah. So I've learned so many things, seeing so many institutions. I thank, my opponent for bringing me into that level, Thank you.
Thank you. Thank you, sir. Thank you for those words of wisdom. Before we conclude the program, Dr. Supriya Phadke, who heads the Community Eye Care Foundation's Vision 8 Center, would just give us a vote of thanks, and then we have the dinner.
Very good evening to everybody. It is an honor to be a part of a wonderful CME. After this event, we hope to become instrumental and guiding force for more visually challenged individuals to live a happy, dignified, productive, and fulfilling life. On behalf of CECF team, it's my privilege to propose vote of thanks to our esteemed guests, Dr. Titial sir, Dr. Maskati sir, Dr. Deepak Bagga sir, Dr. Santosh Agarwal sir, Dr. Kulkarni sir, Dr. Atul Kadani sir, Dr. Mandar Paranspe sir, and Dr. Rahul Deshpande sir. They have not only spared their valuable time from their busy schedule, but also enlightened us with commendable tasks. This has helped us clearing our concepts and enhancing our understanding of low vision and rehabilitation. I like to thank my partners, USA, Vision Aid USA, Rotary Club of Pune Downtown, DuroShocks, Mr. Vikram Desai, who always supported our initiative, encouraged us to strive for excellence. A special thanks to POS, MOS, and Entoad Pharma. I also like to thank Mr. Ramu Mutangi, CEO, Global Smart Health Global, the creators of Smart Vision glasses, for enlightening our knowledge on its uses and limitations. Finally, I like to thank our respected delegates who accepted our invitation, attended seminar, and encouraged us, our speakers and CECF team. Last but not the least, Team CECF, whose hard work has made this event possible. Thank you.
So if you can just come for a group photos.